Thank you, Lisa, for that kind introduction. Kristen and I are excited to present today on breastfeeding essentials for infants with oral facial clefting. We are both very passionate about this area in infant feeding and excited to share our experiences and the literature review with you today. These are our disclosures. So Kristen DeLuca is a salaried employee of Joe DiMaggio Children's Hospital, and she will receive an honorarium from Dr. Brown's Medical for today's webinar. Her non-financial disclosures are that she is part of the coordinating committee for SIG-5, which is cleft and craniofacial anomalies, special interest group. My financial disclosures is I have received a salary as an assistant professor at Nova Southeastern University, and I'm an hourly per diem speech language pathologist at Joe DiMaggio Children's Hospital, and I too will receive an honorarium from Dr. Brown's Medical for today's webinar. My non-financial disclosures is that I do not have children, obviously, and I am very dedicated to our field. So I am a board member of FLASHA, the Hispanic Caucus, SIG-13 Coordinating Committee. I am the Feeding Matters Conference Committee Chair, a NANT peer reviewer, and a NANT Conference Committee member. And these are the learner outcomes for today. What a great way to celebrate the month of July, which is Cleft and Craniofacial Awareness Month. During this talk today, you may hear us using terms such as direct breastfeeding, which is when you are directly feeding your baby via breast, or you may hear us using terms called breast milk feeding, where you are expressing your breast milk and putting it into a feeding system, such as the specialty needs feeder or any other type of system. We know that oral facial clefting is more common than expected in the United States. It occurs approximately 1 in 500 live births, which is more frequently than most genetic etiologies and syndromes. Just to put it in perspective, trisomy 21, Down syndrome, is 1 in 700 as compared, for births versus 1 in 500, which is oral facial clefting. So why is that important? It's important to know that though cleft and cleft lip, cleft palate, and cleft palate is one of the most common birth defects in the United States and worldwide, medical providers are not always as familiar with how to assess and treat this specialized but high frequent population. Oftentimes, medical providers will even admit to parents that they have limited experience working with a specialized population, and oftentimes that leads to a consistent pattern of blaming the baby's cleft when it comes to feeding challenges, informing the parents that they may or may not be doing enough to support their baby, and oftentimes leaving parents in a very traumatic situation where they really don't know which way to turn because they typically may be the most experienced with their baby as compared to their medical provider. So oftentimes these babies are left in a situation where their failure to thrive or medical providers are recommending atypical recommendations such as using an eyedropper to feed the baby or to cut a traditional nipple a hole very wide so the baby can eat. Now, these are very well-intentioned caregivers and healthcare providers, but it's just because of lack of experience working with this very high frequent population. So we're here today to say, as allied health professional, as nursing professionals, and even as other medical professionals, we have to really lead with change and show how we can feed these babies successfully. So to take us back to anatomy and physiology class, yes, we're going that far back. There is an embryonic period and fetal period of in utero development. I like to really think of the embryonic period as the time where all the magic happens, right? This is going to include all major organ growth and development, in exception of the lungs. So typically your heart, your brain, your gut, your esophagus, these major anatomical structures will be developed during this period, but also face morphology will occur during this time. That includes the eyes, the nose, the hard palate, the soft palate, and the head and neck physiological markers. So why is this important? Um, Oftentimes during this embryonic period, the magic hour, the magic period that I like to call it, something can occur that can impact how these major parts of the body, organs, or face morphology are developing. Something that can occur is called a neural tube defect, and that's where a defect is occurring during this process, and that impacts the complete development of something. So it could impact the development of the heart, the central nervous system, the spinal cord, and this is where you would see those types of diagnoses early on, like spina bifida or congenital heart defect. During this time, the embryonic period is where you will start seeing where the chance for clefting can occur, including cleft lip, cleft palate, cleft lip, and cleft palate. So when we think about risk factors during the embryonic period and also the fetal period, we want to really just think of it as multifactorial risks that can occur. The first one is familial history. So that means that clefting can run in the family. Mom has a cleft, grandma had a cleft, great grandma had a cleft, so now daughter has a cleft. So that is something that we often see as a familiar risk factor. Then we look at age. So if your paternal and maternal age does matter. So if you're younger than 20 years of age, oftentimes that's a risk factor when you're female and you're carrying the infant, but also if you have advanced maternal age. So advanced maternal age is over 35. So yes, I am advanced maternal age, but it is putting the mother at risk for being in that category of possibly having some type of neural tube defect or clefting. But also advanced paternal age could be a consideration as well. Absent or inconsistent prenatal care. We know that is something that is very high frequent in our healthcare system currently due to being underinsured or no insurance, or even just having poor health literacy. And then we also know that the absence or inconsistent intake of folic acid can increase the risk of clefting. So folic acid, for those who may or may not know, is essentially like a man-made vitamin that can support pregnancy and try to prevent neural tube defects. So in countries that are not resource rich, so maybe a country that doesn't have as much economic stability as perhaps the United States, they don't have access to folic acid, you may see higher numbers of clefting that can occur. And then lastly, another risk factor can be teratogen exposure. So that would be those types of any type of infection that the mother has during the in utero process, any type of drug exposure, alcohol exposure, even radiation exposure or mechanical compromise, such as having some type of accident. So we know that feeding and swallowing starts during the fetal period of gestation. We wanted to provide foundational milestones today that are what we're expecting during the in utero process. So we're all on the same knowledge base. So we can all use that knowledge base to help us understand breastfeeding and oral feeding differences in this specialized population. So we know that current literature shows that infants are swallowing embryonic fluid as young as 14 weeks gestational age and have increased swallowing opportunities as they mature. In the past, if an infant was born premature, in the past, I would say probably like 5 years ago, 6 years ago, we would often trial oral feeding as young as 31 to 32 weeks gestational age, postmenstrual age. But we now know from the clinical science that that does not increase independence to oral feeding nor decrease length of stay. So the current research, the current literature is showing that the potential for oral feeding practice can be as late as 33 to 34 weeks post-menstrual age, and it does not impact length of stay or independence to oral feeding. And when we think about oral feeding, our minds should go automatically to how does the baby create a seal? How does the baby compress the nipple? And how does the baby create suction? And this is a pressure-driven system that we'll be discussing at length over the next few slides. So an infant will complete a seal when they achieve labial closure around the nipple. Then the baby should create lingual cupping, which is when their tongue does that nice U shape around the nipple, and then that will trigger lingual palatal elevation and help with creating compression, which is going to trigger positive pressure inside the mouth. Lastly, as the tongue and palate contract together, we are going to achieve negative pressure, which is where their suction is going to occur. And that's what's really going to impact milk transfer, bolus size, and milk flow. So clefting, including cleft lip, cleft palate, and cleft lip and cleft palate, are considered an anatomical structural deficiency that directly impacts the mechanics of oral feeding. Research demonstrates that children with cleft lip, cleft palate, or cleft lip and cleft palate, in the absence of any other congenital, respiratory, upper airway, neurological differences, has minimal to moderate effect on their feeding success. So what that means is if it's an isolated cleft lip, cleft palate, or cleft lip and cleft palate without any other medical comorbidity, there really should not be a feeding impact, except with that there's an anatomical difference. So over the next few slides, we will discuss how the infant's obligatory anatomical difference impact the mechanics of nipple feeding, including breastfeeding and traditional bottle feeding. So typically when we're doing lit reviews, myself or Kristen, we are typically using articles that were published within 5 to 10 years. But this is a true hallmark study in the field of feeding with infants with orofacial clefting. So it's extremely important that we discuss it today, even though some may consider it vintage. Reed et al. Completed a prospective observational study that looked at 40 infants with cleft lip, cleft palate, and cleft lip plus cleft palate, with and without genetic etiologies. They had a control group that had non-cleft babies, and then they had experimental group with cleft lip, cleft palate babies. They hooked up the babies to a blood pressure transducer to measure the suction phase when they were feeding to really determine how the baby was completing compression and suction and how they were able to create milk transfer. Babies that had cleft palate or cleft lip and cleft palate were using more compressible nipple adaptive feeding systems. And this is before we have the current feeding bottles available to us. So this is using more of a compressible nipple type bottle. And the cleft lip babies who did not have any palatal involvement were using a non-compressible bottle, so a more traditional bottle. So what this study found, and it is a hallmark research study, is that infants with cleft palate and cleft lip and palate have mechanical deficits secondary to their anatomical differences. This means that a baby that has a cleft palate and a cleft lip or a cleft palate alone are not able to create any suction compared to their peers who do not have any cleft palate or cleft lip and cleft palate. What they also found is that if a baby only has a cleft lip, they can achieve the same level of suction and compression as their non-cleft peers. So essentially, this article is one of the first to demonstrate that if a baby has a cleft palate or a cleft lip and cleft palate, they cannot create that negative pressure to create milk transfer with traditional nipples or with any type of nippling. It also demonstrated that if a baby has a very small posterior cleft, that they may be able to generate some suction, some negative pressure, but it will be weaker and they will fatigue over time. So again, this is very, it's good information to have, but we still want to be mindful that this population will still have issues with creating negative pressure. And then this is another great vintage article, but with critical data findings that identified that infants with orofacial clefting do have differences with their sucking patterns and their sucking duration. So this had a control group of 20 infants with no orofacial clefting, and then experimental group of about 42 infants that had cleft lip, cleft palate, or cleft lip, or cleft palate only. And what they found was that infants with orofacial clefting have shorter sucking burst durations, yet try to suck faster. So if you look here at this swallow study, and I will say we typically don't do a swallow study for isolated cleft lip or cleft palate, but when you're watching this video, you can see that the infant is having shorter sucking bursts, but sucking faster in an attempt to have an excessive amount of compression. So as we go along today, and we're talking about cleft lip and breastfeeding or cleft palate and breastfeeding, when we think about seal, compression, and suction, it's important to know the function of each. So for a baby with cleft lip only, the seal, how they wrap their lips around the nipple, will be impaired. The feeder can use their fingers to promote labial closure, or if the mom is breastfeeding, she can use her breast tissue to fill the space if possible. The compression and the suction for a baby with cleft lip, just like the Reed article told us, should be normal. They should be able to create positive, negative pressure if there is no palatal involvement. So again, this is isolated cleft lip, and they should be able to breastfeed from what the research shows us. When we look at cleft lip and palate, so meaning the baby has a cleft lip and a cleft palate, their seal would be impaired because we know, again, they're not able to create that seal. But their compression and suction will be impaired as well. Compression will be impaired because the positive pressure will be almost hyperfunctional. The baby can achieve the positive pressure for compression. So this is where they're, clamping down on the bottle. But it's hyperfunctional. It's almost like they're compensating. So it's too much compression that they're doing. And then suction is impacted because just like the Reed article found, the baby does not have the ability to create negative pressure. And when you're not able to create that negative pressure, you cannot create milk transfer from the nipple. And then if it's a cleft palate only, so no cleft of the lip, the seal of the baby should be intact and this should not be impacted. If the baby has a cleft palate only, we know that compression can be impacted like we previously discussed, but with that increased positive pressure and almost hyperfunctional. Versus suction will have impaired negative pressure, but remember, if it's a cleft of the hard palate and the soft palate, they will likely not be able to achieve any negative pressure. But if it's a very small cleft of the soft palate, very, posterior, they may be able to create some negative pressure, but we need to think about it with caution. So this is just a quick review of what we've covered thus far. And these are recommendations for direct breastfeeding practices with orofacial clefting population. This is specifically designed for resource-rich countries like the United States. I do want us to pay attention to the chart all the way to the right that talks about clefting of the soft palate. So that's that small posterior cleft. We do need to be guarded. Even though the Reed article identified that they can create some pressure, they may not be able to exclusively breastfeed and will likely need to have an adaptive feeding system to supplement.
Thank you, Rocky. I would like to share the most recent revision of the American Breastfeeding Medicine's protocol and guidelines for breastfeeding infants with orofacial clefts. It is available for a free download, and you can see the QR code on the screen. It provides feeding recommendations of which the quality of evidence for the techniques discussed in the paper are rated as per the Oxford Center for Evidence-Based Medicine. Much of the literature on this topic is limited, and available evidence is largely anecdotal and sometimes contradictory, making it a challenge for all of the professionals to be on the same page when feeding infants with clefts. I really like the appendix in this protocol. There's a nice question and answer section that I use when providing education to ancillary support professionals in our organization and beyond. To gain a better understanding of breastfeeding practices in the United States, Kay et al. In 2018 performed a pilot study of mothers' breastfeeding experiences with infants with cleft lip and palate. It was a retrospective telephone survey from 50 mothers from their particular institution. 78% initiated the use of human milk for a median duration of 4 months by the way of exclusive pumping. Only 32% provided express breast milk for 6 months or more. And poor supply was the most frequent challenge to providing human milk and led to cessation in almost half of the mothers by 4 months of age. Formula was used to supplement for poor supply or poor infant weight gain in 90% of the mothers, and only 36% of mothers reported individual encouragement to provide human milk, and 18% reported they were specifically discouraged from providing human milk for their infants. Madhoun et al. In 2020 performed a similar study. However, the mothers surveyed were from their particular institution along with mothers across the United States using social media platforms and an online survey. So this totaled 150 mothers with infants with cleft lip and palate. 46% of mothers of infants with cleft lip and palate provided breast milk to their infant for at least 6 months. So this was slightly higher than what Kay et al. Reported in 2018. However, still both percentages were lower when compared to the national estimates of the general population of infants without clefting. 5% of infants ever fed at the breast, and 43% received pump breast milk via bottle. The study also looked at the feeding device, the adaptive bottle that was used. And as you can see, Dr. Brown's specialty feeding system was the primary bottle, reported at 59%. So this was really not very surprising, as I would venture to say that most large children's hospitals that are associated with the cleft team are now using this bottle. And perhaps it's the smaller community-based rural hospitals that either don't have access to this bottle or awareness of this bottle just yet. So when assessing, when Madhoun et al. Looked at barriers to direct breastfeeding and pumping, you can see here from the majority of infants were not able to transfer milk from the breast and had difficulty latching on, which would be expected. And regarding pumping, almost half of the mothers reported a lack of supply of express breast milk for their babies, and that pumping was uncomfortable and or painful. So the takeaway here for me with these two studies is the question of how do we make exclusive pumping for these mothers more doable, and how do we proactively support their goals of providing human milk to their babies? So keep these questions in mind, as later in the presentation, we'll be discussing some simple strategies that I found helpful to help our families on this breast milk feeding journey. So here are the listed feeding differences one would expect for a baby with cleft palate versus a non-cleft peer. So they will have difficulty expressing from the traditional nipple or breast if they have that cleft palate. They will have an inefficient or ineffective compression and suction. They will have nasal regurgitation. It's expected. We want to counsel our families that it will happen, that it's not harmful, but there is no separation between the oral and nasal cavity. We will also have noisy wet breathing generally after feedings. And what this is that's when the formula is getting up into the nasal passage. Babies are obligate nose breathers. And so you will hear that wet, noisy breathing different from, let's say, like a wet vocal quality, when that you would suspect aspiration. They can take an excessive air intake because they have the lack of seal and that lack of negative pressure buildup. And then they may have some inadequate volume of oral intake. So how do we combat these feeding differences? we use direct interventions, and I like to organize these interventions into 3 categories, including compensatory strategies to overcome the infant's structural and mechanical deficit, nutritional support, and then psychosocial interventions. So in the first few days of life, mothers produce colostrum, and this is the first phase of breast milk. Colostrum has tremendous benefits for the infant, including immunological support, GI support, and can prevent low blood sugars and lessens the risk of jaundice. So with a typically healthy full-term infant, they're brought to breast within the first hour of life to colostrum feed. Our infants with cleft lip and palate, or specifically cleft palate, are unable to transfer the colostrum through direct breastfeeding, and they should be offered the colostrum via syringe, via spoon, or even a parent's finger. The best method to collect the colostrum is through hand expression, as it's a very viscous, thick material, and often a pump alone will not most effectively pull the colostrum from the breast. So this should be performed frequently along with pumping until the next stage of milk, the transitional milk phase, begins usually within the 2 to 5 days of post-birth. Infants with cleft palate, with or without cleft lip, will rely on that adaptive bottle, which should be assessed taking into account baby's safety of swallow and their feeding efficiency. And then additionally, there is something out there called the Supplemental Nursing System, and this is by Medela. And this is a device to consider to support those mothers who greatly desire to direct breastfeed. If this method is considered, collaboration amongst the SLP and lactation is extremely important. So when we look at positioning for the infant, we recommend a 60 or more degree angle, and this will assist in the bolus transfer, while also decreasing the tendency of nasopharyngeal reflux, although the NP reflux will happen and it will be expected. So again, we want to prepare our parents for that. If breastfeeding an infant with cleft lip only, it's recommended to orient the cleft lip toward the top of the breast using a football hold or a face-on straddle. So when we look at adaptive bottle selection, we want to make sure that the baby is safe and efficient. So this baby came into our team, has a unilateral cleft lip and palate, and came in using the Medela special needs feeder. So you can see here, parents reported suboptimal weight gain. He was insufficient in feeding, and his feedings were taking over 30 minutes for his goal volume. So we then trialed different bottles. The next video that you'll see is the Dr. Brown specialty feeding system with a level 2 nipple. What I want you to notice here is that there's some mild stress cues. He's pulling away. You can see there was some anterior bolus loss and some audible gulping. So then we quickly changed that bottle and went to the Dr. Brown specialty feeding system with the level 1 nipple. And you can see here, he's very comfortable, not demonstrating any stress cues. And this particular flow rate was the most safe and effective for this baby to feed with. So this little guy was seen at our team at 5 weeks of age with a diagnosis of Pierre-Robin and cleft palate only. He returned back to birth weight at 4 weeks on exclusive breast milk. Mom was pumping. Because it took him 4 weeks to get back to birth weight, which we do know there has been research published that it can take babies with cleft palate up to 4 weeks to regain their birth weight. The pediatrician did become alarmed with suboptimal weight gain and let the parents know at week 5 to offer only formula. So the parents came to team, and again, not sure exactly how the pediatrician worded that, but the parents' perception was that this infant could not thrive on mother's milk, and mom was kind of grieving the loss of providing her baby breast milk. They also reported that with mom, a feeding took around 45 minutes, but with dad, it was half the time. So I first started and I asked mom to feed the baby. Rocky, you can cue that up. Thank you. So I want you to notice how mom's feeding the infant. He's in a semi-reclined position in mom's arms. There's very minimal head support. There's really no head support. And I want you to note the nipple is not completely placed in his mouth. I see this often, and I have to encourage the parents to have those lips touching the collar of that nipple, therefore allowing the most compression of the nipple and the optimal flow and coordination for baby. So in this video, while mom was feeding, he took 15 milliliters in 7 minutes. So then I had asked dad to feed him. And I want you to notice much better positioning. You see that dad is providing appropriate head, neck, and trunk support, which is providing increased stabilization for the baby. And the nipple is completely in the mouth with the lips touching the white collar. With these techniques implemented, he accepted 37 milliliters in 7 minutes. So it essentially, positioning alone cut his feeding time in half. Additionally, our team dietitian supported this mother's desire to continue to provide express breast milk, and she increased the caloric density of express breast milk using powder formula and 2 booster feeds of formula. So here on this slide is just pictures of positioning. So you can see here on the right, this is the football hold. This was my baby, did not have a cleft lip, but did feed best in the football hold position. And then on the left here, you can see a mother that did breastfeed a baby with the cleft lip and cleft palate. And you can see she's holding them in a way, supporting them with that football hold, but I want you to take close note. She is compressing that nipple. And so compression of the nipple is, if you have any baby that does need to direct or wants to try direct breastfeeding, compression of the nipple is what they will need to extract that milk. So some of our infants may have wide jaw excursions due to the inability to create suction and the increased need for compression on the nipple due to the open palate. Chin and cheek support can assist in jaw stability, reduce jaw excursions, therefore making infants more efficient with their feeding. And then use of external pacing can also assist if the infant has a disorganized suck, swallow, breathe, and needs help maintaining respiratory patterns during feeding. Infants with cleft palate will ingest more air than a non-cleft infant due to the inability to create a tight seal. So burping is recommended more frequently, around 1 to 2 ounces, or during a natural break in feeding times. So other nutritional interventions, smaller, more frequent feedings may reduce the fatigue and help improve the infant's nutritional and caloric intake in a 24-hour period. So this infant below was born with a unilateral cleft lip and palate, and parents were discharged from the hospital and told to feed every 3 hours. So when the infant came to team, it was obvious he fatigued with the larger gulp feed. So therefore he would fall asleep, and then 20 minutes later, he would demonstrate continued hunger cues that the parents just were not picking up on. So I provided a feeding log to the family. You can see an example of our feeding log here. And we recommended feeding every 2 hours in smaller volumes, and ideally keeping the active sucking during that feeding to less than 30 minutes, keeping that feed lower than 30 minutes. You can also see in the log, we did ask the parents to let us know how much formula versus express breast milk they were doing. And so this baby was able to have more efficient weight gain because he took about 2 to 3 ounces more in that 24-hour period with smaller, more frequent meals. For any baby that has that we are concerned with suboptimal weight gain, we do always recommend weekly weight checks. And then should they be directly breastfeeding at the breast, doing a pre and post weight to see how much volume they took in during that breastfeeding session. And then I kind of talked briefly about this, but fortified feedings is another strategy that we use very often for our babies with cleft palate. Breast milk is generally considered to be 20 calories per ounce. However, this varies dependent on external factors, including mother's diet or the ratio of the foremilk and hindmilk composition for that particular mother. Foremilk is more of the it's the beginning milk, it's more of the skim milk, with the hind milk being more of that fatty milk. So to increase calorie contents of breast milk, I usually recommend a lactation consultant to help that mother with, help her with the quality of her diet, help her with additional supplements. There is some evidence that sunflower lecithin can improve hind milk production, that fatty milk. And then that lactation consultant can also ensure adequate pumping techniques. Further lines of defense, should we need, is we can use human milk fortifier powder that is very expensive, so not often done. Generally, we use infant powder formula and add it to the breast milk to increase the calories per ounce. And we can use a standard formula, or there are specialized formulas that have higher calorie per ounce needs should it be medically necessary for that baby.
Thank you, Kristen, for that great overview of different interventions for nutritional support and compensatory strategies when thinking about breastfeeding. Skin to skin is a feeding strategy that really supports the mom and the baby to create that connection that all mothers want with their child. During skin to skin, a mom will be able to really start identifying what her baby does on a regular basis, including the baby's state regulation, oral readiness cues, respiratory patterns, and even simple body movements. Anecdotally, I've noticed that mothers who have a baby with a cleft, and again, this is anecdotal, don't always do skin to skin with their baby because they are not directly breastfeeding. But we know that skin to skin has properties that are not just going to help the baby with their own state regulation, but also help the mom with her own milk stimulation and reduce her stress and anxiety that she may be having. So skin to skin all the way, regardless of if we're breastfeeding or not. It's a great psychosocial strategy. And then pumping support, that is something that is difficult because pumping is a lot of work. So we like to make sure we're providing as much pumping support to the parents as possible. And one of the ways we can do that is by recommending a hospital grade breast pump. Kristen will talk about in a little bit when she works with families, she will provide a letter of medical necessity to them so they can ask for a hospital grade pump, breast pump, because they will be able to get more milk expressed as compared to a commercial pump or wearable pump like the Freenie. So when they're getting this pumping support with a hospital grade pump, we know that is going to reduce any type of breast infection and really support breast health during the milk breast pumping journey.
So pumping for these mothers is a full-time job. I've had the opportunity of breastfeeding and pumping with my 4 babies. And it's not until that time did I realize what a commitment exclusive pumping truly is. That video there on the left, I pumped so much with my last baby that my then 2-year, 10-month-old apparently got the hang of it as well. And I caught her on camera pumping. So I just, when I saw her, I was laughing out loud. But following my own experiences, I began learning more as to how to support and encourage the mothers I worked with who wanted the same for their babies. Should you want to delve in more on this topic, I do recommend the book Exclusive Pumping Breast Milk by Stephanie Casemore, and that QR code is there to a link to Amazon. So a few slides earlier, we discussed the primary reason for human milk cessation, which was the loss of supply of mother's breast milk. So in my quest to help these mothers, I learned of Dr. Jane Morton. She's a physician at breastfeeding medicine at Stanford University. And she speaks to the importance of hand expression to encourage early initiation of milk and for increased milk supply later on. So hand expression generally falls under the scope of the lactation consultant. However, on our team, we do not have a lactation consultant as part of our core team. So therefore, I did become more educated on this topic. So in 2009, Morton et al. Published a study on combining hand expression with electric pumping, and the results of the study were quite remarkable. You can see the picture below demonstrates the technique of which the mother is compressing the breast while the breast pump is providing the suction. So this really makes perfect sense, as the compression that mom provides along with the suction of the pump really truly emulates how a non-cleft infant feeds at the breast. So the study showed that milk production was influenced by three factors: pumping frequency in the first 2 weeks, frequency of hand expression, primarily in days 1 through 3, and then hands-on pumping. So these two graphs depict the findings from their study. So the bar graph on the left depicts the volume of milk pumped on day 14 for the three different groups. So the green group, the green bar, having the lowest volume, only hand expressing 2 times or less, with the red bar depicting the greatest volume of milk with hand expressing greater than 5 times per day. So the line graph on the right then plots the pumped breast milk volume over 8 weeks time. And so you can see the red group pumped the most at 955 milliliters per day, with the green group pumping the least at 680 milliliters per day. So in 2012, they did a subsequent study that looked at the breast milk samples from 52 mothers and analyzed the nutritional density of the milk pumped. So it did find a higher fat composition after using hands-on pumping, with almost double the amount of fat when compared to the typical range of pumped milk without hands-on pumping. I do need to note that this study was the only study that had this finding that assessed this. And so Dr. Morton suggests that this is can be very important for our babies that are exclusively pumping, and this study should be replicated. So I encourage you to check out Dr. Morton's free website, firstdroplets.com. So on the screen, you can see all the current videos that are downloadable and created for mothers in a very understandable, digestible format. The videos that I most use for counseling when I do prenatals, I've provided the QR codes above. And additionally, Dr. Morton will be creating a section for professionals, which will go live in July, which I encourage you to check out.
So as we finish talking about how to support the mother on their breastfeeding journey, now let's kind of change our focus on the prenatal counseling aspect of working with infants with cleft lip and cleft palate. The prenatal diagnosis of cleft lip can typically be identified between 11 and 13 weeks gestation with about 35% accuracy. And then as the baby gets older, around 20 to 24 weeks, cleft lip can be identified through ultrasound, about 60% accuracy. The diagnosis of cleft lip is in utero is typically feasible because it's exactly on the face morphology when they're looking during their ultrasound. But just to please note that cleft palate typically is not something that can be seen on ultrasound. So when we're doing prenatal counseling and it is a multidisciplinary approach that we use, we do counsel for both in the event that the child has it. And our team, and Kristen will talk a little bit about what we do, but prenatal counseling is a multidisciplinary interaction. So you will have the opportunity to work with your nurse coordinator, your nutritionist, and your speech language pathologist or occupational therapist. Prenatal counseling, it has been shown to reduce stress and anxiety for the parent as they're moving into the new normal of their baby possibly being born with a cleft. It provides the parents with very digestible information that impacts them immediately, nothing long term, but immediately, like how to use adaptive bottles, how to complete hand expression, breastfeeding expectations, possible NICU admission, and how to be their baby's advocate. That includes bringing specific bottles to the hospital in the event the hospital doesn't have it, and how to advocate for their baby in case they need further support in the hospital with a speech or occupational therapy consult. We know that current published clinical science shows that prenatal counseling for orofacial clefting is a proactive, trauma-informed practice. We also want to recognize today that prenatal counseling in all clinical settings may not be possible. Why? you really can't bill for it. It's not something we can get reimbursed for, especially for allied health professionals. So this will impact productivity and scheduling in some institutions. So please refer out to your craniofacial and cleft palate teams if you're not able to provide that in your community. Additionally, we need to think about the social determinants of health and how some families will have reduced access to medical providers to achieve this counseling, as well as may not have the same health literacy.
So just to give you a brief overview of what we do at our prenatals. So I first go over the adaptive bottles, and Dr. Brown's has actually made it very easy for me because I used to review 3 different bottles, and now I really just show them the Dr. Brown's specialty feeding system. And you can see here, I think you can see that bottle. Here is the infant pace feeding valve, which is really the main difference between their standard bottle and then the adaptive bottle right here. So this nipple, this valve, the pace feeding valve is placed right there in the nipple. So I go over the bottle with the families. I also ask them the caregiver's preference for feeding. How did you want to feed your baby before you got this news? And support them in whatever they let me know. Now, I do have families that will say, I'm, formula feeding, breastfeeding didn't go well for me the first time. And, I listen and I validate, and, I say, well, what a fed baby is bet baby. And then I go over hand expression. And sometimes, talking about hand expression, talking about colostrum feedings, sometimes just by doing that, I've gotten a few families saying, that seems really easy to do. So I'll do that. And so that's just an extra benefit for baby. No matter if they're having colostrum for the first few days, or if they're even having breast milk for the first 2 to 4 weeks of their life. Talk about pumping. Rocky covered, that we give a letter of medical necessity for pumping. Should they need, and I generally will let them know if they do want to offer exclusive breast milk to their babies, that I do recommend a medical grade pump. And we talk about the hands-on pumping, and I give them those videos to watch through First Droplets. So let's talk about a case study. So this was a 35-weeker that a female, and she was born at a community hospital around 3 hours away. She was admitted to the NICU due to her prematurity status. She did have a small VSD, and she had a small cleft of the soft palate, and therefore had feeding difficulties. So our surgeons, they travel to many community-based hospitals. So that's how they found out about our team. And the family reached out to me on day 6 of life, and with primary concerns of feeding, and they reported discrepancies between the feeding recommendations amongst the nurses, amongst the speech pathologists, and amongst the physicians. So there was lots of different trials of bottles. They had them on a regular bottle. They had them on the other cleft adaptive bottles, but mom just it didn't sit well with her. They were getting very many mixed messages. So we did schedule a telehealth feeding consult at 7 days of life. So that is one of, I think, the best things that has come from the COVID pandemic is the use and easy access of telehealth now. So I was able to telehealth right to her NICU room to provide recommendations and to watch a feeding. So this picture was taken a bit later on in life, but it gives you a really nice view of her intraoral cavity. So here on the left, that is before the cleft repair. So again, lip is intact, gum is intact, the hard palate is intact, part of the soft palate is intact. So it is a very small cleft. And then right was after surgery. So she was on a PONG feeding plan in the NICU. They had her feeding every 3 hours, and the goal was 60 milliliters per feed, with a total volume of 16 ounces in a 24-hour period. Mom was pumping express breast milk, and she was also supplementing with formula. And so during that feeding consult at 7 days of life, she did immediately latch to the nipple, which many of our babies with cleft palate do. She had that 1-to-1 suck swallow ratio. I'm sorry, so we went with the Dr. Brown specialty feeding system. And I started with the transitional nipple because she was premature. So with that system, she had audible gulping, anterior bolus loss, mild stress cues. She had 1 DSAT to the low 90s with slight color change. So we discontinued because that nipple didn't appear safe for her. And then we slowed down the flow a bit and switched to the preemie nipple. And so although her suck to swallow ratio did increase slightly, there was no audible gulping, no stress cues, her SATs were fine. And so she accepted 15 milliliters in 3.5 minutes. So that was my ultimate recommendation. I had to write it. It was put into the medical record there at the hospital that this was the system that she was to consistently use to promote PO feedings. I also had recommended smaller, more frequent feedings. They did because she fatigued, and they did have her feeding every 3 hours. And this was approved by the hospital simply because there was one parent that was always present and they were able to do the feedings. So within a few days of using that system, smaller, more frequent feedings, she got rid of that tube. But mom, during this time, had a really strong desire to breastfeed. And so I discussed the importance of skin to skin, discussed the importance of continued pumping with the hospital grade pump. And, really let's get her out of the hospital using the bottle, discontinue that NG, and then we can start the work of direct breastfeeding. So she was discharged home on day of life 12. And so I did recommend the supplemental nursing system by Medela. And with lactation consultant support. So mom got on it, found herself an amazing lactation consultant. So you can see here, this is the starter system, but you see how mom kind of worked on putting it in her hat so she wouldn't have to tie it up. And the tape, every feeding mom would tape up, bring baby to the breast. And so we did another telehealth session at day 31. And so using the FNF system, the baby had a shallow latch and she was able to take 40 milliliters in 10 minutes. So when mom noted the fatigue, which baby would fatigue pretty quickly, then she switched to the Dr. Brown specialty feeding system, but that was able to up it to the transitional nipple at that point because this was 31 days. And she accepted 100 milliliters in 8 minutes. So mom did this system. Again, her goal was she really wanted to have that palate repaired and then bring baby to breast and breastfeed and be an extended breastfeeder. When mom understood that the cleft would be repaired at 8 months, and just the stress of getting the whole system tied to her and taped up. She did this for 6 weeks and then she ended it. And she grieved the loss of direct breastfeeding, but she was, an amazing pumper. The lactation consultant had recommended that sunflower lecithin that I briefly spoke about to increase the fatty content of her milk. And that really helped. And so this is now the mom that during our prenatals, should a parent really have a desire to exclusively pump, she is now our connection. So she is kind of like our internal support for other moms because she's been through it and she's now brought her baby. Her baby's 12 months of age and she has been exclusively fed breast milk.
Thank you, Kristen, for sharing that really powerful case study. It just shows that it really does take a team to support a baby and their mother and their caregivers. We did want to share some resources today. The American Cleft Palate and Craniofacial Association has a lot of great information on how to work with infants with oral facial clefting, including breastfeeding and bottle feeding. So that QR code will take you to their great website. We have other resources for the clinicians today, including leadersproject.org and First Droplets. And we wanted to thank you so much for your time today. Our collective passion, engagement, and advocacy for this population is something that really pushes us to do our best every time we walk through those doors of the hospital. And we can't thank you all enough for listening to us share our experiences with you all today. So here's our contact information, and we hope we can connect soon. Here are our resources for your review. Thank you so much.
For our full-term infant, I try the level 1 nipple, and that's usually does the trick. Yes.
Okay. And then obviously people would be, discussing about watching with stress cues and how the baby tolerates it and all that. So, okay, great. How about, this is a key piece, I think, clarifying, is breastfeeding for babies with cleft palate not recommended because it's unsafe or because it's inefficient and ineffective? Is breastfeeding for pleasure recommended? And I know you spoke to some of the research about that. So I'll let you two decide who's going to answer that one.
Thank you. That's a great question. So if a baby has an isolated cleft palate or a cleft lip and cleft palate with no other genetic etiology associated with it, typically they have a typical pharyngeal phase of swallow. They're not at risk for aspiration. The anatomy alone is what's causing that obligatory error, that obligatory issue that's impacting their suction and their compression and being able to achieve milk transfer. So essentially, because of the unrepaired cleft in their hard palate or soft palate, they're not able to be an efficient feeder and transfer the milk. So like when we showed the swallow study, we typically, I'll be honest, unless there's huge red signs or red flags with the baby, I typically never do a swallow study with a baby who has a isolated cleft lip or palate.
Thank you for clarifying that. All right, how about, do you happen to have any numbers on how many of your families, maybe it's a statistic or percentage, are successful with hand expression and compression with breastfeeding infants with cleft lip and palate? And do they do it exclusively or still supplement via bottle?
So I have to say, in our team, it's very similar to the research that Medhoon found that I would say really only a handful of babies are being fed exclusive breast milk beyond 6 months of age. I find that I think we have to do a better job of encouraging the mothers. I think that there was a question earlier. In one of the studies, they found that 18% of the mothers were actually told not to provide breast milk. Now, again, that was a survey from mothers, so that was their perception. So, we just have to realize that that's what they heard. That's maybe not what they were told. But I will say that it is a very low percent of our babies that are being fed exclusive breast milk for even 6 months of age.
Great, and great emphasis also on reminding us that encouraging breastfeeding and pumping is a team effort, not just one person or one discipline's responsibility. Thank you. Do you provide families with scales if they desire to breastfeed so they can do pre and post weights?
Yeah, that's a really great question. Kristen and I actually spoke about this at length like 2 weeks ago. We were together for a trip and we were talking about it. Currently, what we recommend in our team is to go for weekly weight checks with their pediatrician. So that way that interprofessional collaboration is occurring, where the pediatrician's office is talking with the parents are talking to our team, and we're able to really just confirm that the baby is getting that good growth that we're expecting. There are other teams that are out there that do provide parents with scales, but that typically is like a grant funded option. Hopefully in the future, that's something we can do. So.
I will say I have had parents that will just go on Amazon and they'll buy an infant scale. So that's really the most important thing, that it's an infant scale, and they run around $40 on Amazon.
Great. Thank you for that tip. Okay. We have so many questions. I'm going to do one more because I know we're running short on time and people have to get back to their days, but people want to talk about a lot about prenatal counseling. Why are some prenatal counselors or clinicians recommending specific bottles before the baby's born? What are some ideas you have about this?
I'll take that. I actually have to say that in my years of doing this, and since the Dr. Brown's bottle has come out, I am one of those clinicians that does recommend the Dr. Brown's bottle in our prenatal appointments. There are several reasons for this. I find that our babies do best with this bottle because it is self-paced driven. The other bottles you do have to squeeze, and so sometimes the babies don't do as well. I find that this bottle is the easiest for the families to use, and it actually is the most cost effective. It's about half the price of another bottle. So when we're doing prenatal counseling, as Rocky said, we don't, it's very rare that we see a cleft palate on the ultrasound. So we are counseling. We know that the baby's being born with a cleft lip. So I let them know, if your baby does have a cleft palate, then this is what we will do. I always recommend, the other reason why I specifically talk about this bottle in prenatals is not all the hospitals have them. So most of the hospitals do stock the Medela special needs feeder. So, you know, I let them know, I tell them about the bottles. If this is what you want to choose, this is what our team recommends. And then I let them guide, you know, what they'd like to do. Most of the time they like the bottle.
And I'll just add as well, in the event that the baby is having flow rate issues, or possibly a risk for aspiration, or just disorganized, having that ability to go between flows up and down, you know, all the way down to the ultra preemie, to the preemie and up, gives the parents a lot of autonomy to know that they can really help their baby and have options versus having to look at other means for nutrition hydration. So that's been a big game changer too.
Yeah, and then to preface that, I will always say, your baby is unique. Your baby, when they are here, will guide us. And so should they not do well with this bottle, there are other bottles. A speech consult, you know, you will have a speech consult and someone will work with you to find the best means.
Thank you. And I really appreciate both of your honesty and transparency about that as well. So we still have over 200 people out on, and this one I think is a big one. It's important. I'm going to do one more. I promise. Last one. Is there ever indication of fees versus a swallow via, you know, video for these babies? So that's a big one. I think people want to know.
Yeah, I think that's a great question. Again, if it's an isolated cleft lip, cleft palate, or cleft lip and cleft palate, you're typically, there's usually not an indicator of the need to do an instrumental study. I am a big proponent of doing the study that's going to give you the most information for your baby. I do infant fees, but I do think a video fluoroscopy, a modified barium swallow study, is going to give you that lateral projection, so you can see all phases of the swallow and really determine where the breakdown for swallowing is occurring and how you can best fit that baby. Because with the fees, you're only getting that superior view, so you're missing that whole oral phase and seeing if there's any nasal regurgitation and things of that nature. So looking at the whole valving system of the oral phase and the pharyngeal phase really gives you more information from the modified barium swallow perspective.
Great. Thank you for explaining that. All right. I think that's all we have time for. Thank you to both of you. I know that our viewers have especially really enjoyed this webinar today. So it's been great information and I appreciate your expertise.